Bam. Now hey, be careful what you say.
Cooking with gas. All right. Cool. Welcome, guys. So we're gonna be going through like mostly a bunch of cardiac stuff with a little smattering of a couple of other random things at the end, but there was a bunch of cardiac arrests in January and some other interesting cases. One that made me still makes me feel extremely anxious every time I look at the EKG. So I can't imagine what it made folks feel like when they were there. We're gonna start with Dr. Richards, kind of going through a STEMI case, just since that is not my wheelhouse necessarily. So go ahead, Dr. Richards.
This is 4090.1 Towpath. Cross streets of March Willow, Cattail Lane. PSC 304, timeout 1507.
All right.
There you go. All right, thanks, Dr. Cheatham. So this is there were a couple of STEMI cases that I was actually just kind of more interested in. I think I'm pretty sure that the same at least duty day is around. So if folks who had this run, I'd be kind of curious, and actually the next one as well. But so it's a 56-year-old, pretty good symptoms, dizzy, weak, pretty much like back pain and shortness of breath. So while the patient themselves necessarily didn't say like anterior chest pain, you clearly were thinking, all right, this is chest pain equivalent. I mean, there's enough there that I'm sure most of us would, but still, just to kind of leave that stated that it wasn't necessarily anterior chest pain, and we still picked up and did 12 lead and did all the right things. This is interesting, is that actually you guys were called out, the same crew was called out earlier in the day, had a right bundle on the 12 lead that was read out. We were like, you should come to the hospital, like, let's go get checked out, and then call back. So a couple things. So one is, and while I feel like I probably haven't said this recently, I like to say it as much as I can. I'm glad I have an opportunity to say it here, which is to say, if someone calls you back and they refuse, you guys are so good about saying, like, you know what, if things change, or if you change your mind, give us a call back. And that's exactly what this happened in this situation. Just because they end up refusing once for any number of reasons, it doesn't mean that they shouldn't call us back. And especially if we're kind of thinking about, it used to be kind of like that COVID protocol, which is kind of, sunsetted now at this point. If things change, like, give us a call back. And so for you guys to be, receptive to that, for them to feel like they can give you a call back, I'm glad that happened. He was taking that medication Ozempic, which I meant to kind of look up, Dr. Cheatham, maybe you did as well. I actually don't know if there is like STEMI risk factors when it comes to Ozempic. Now, clearly people who are on Ozempic probably have some degree of elevated cardiac risk just for being on it for any number of reasons. But I don't, not that I've heard about, at least, and someone correct me if I'm wrong, but I don't think it's supposed to have direct cardiac side effects, but I might be wrong about that. He does have some supplemental hormones in the form of testosterone. Typically, it's more like the estrogen-containing compounds that you worry about for like pulmonary embolism, but we'll keep that in the back pocket, especially when it came to like right bundle. The blood pressure looked okay. Patient actually looked okay. And then we got the 12 lead that showed right bundle, kind of an anticipation, and then the computer read out as STEMI. So I forget, Alex, do you have that 12 lead for the next slide or no?
I do, yeah.
Okay, let's take a look at it. So here's what it read out. And I agree with your all's read. And I, definitely agree with, escalating it, especially if you're getting that 3-star read at the top, right? It does look more like a right bundle pattern to me. And then you definitely have, especially like in V4, V5, you kind of have some upslipping. Sometimes you can get that with hypertrophy and bundle branch blocks and all the rest. But I'm glad that, we did a manual interpretation. We had kind of one interpretation in mind, but when we're seeing kind of that automatic read, at least calling it as such. All right, so then armed with that information, we made our way to the hospital. And here's where I am more just kind of curious, but I'll have an observation is that we ended up, so the run itself, unless I got the address wrong, but I'm pretty sure I got it right, was kind of on the southeast side of the township. Patient requested to go to Bethesda Butler. And at some point along the way, and I have to imagine / hope that was probably relatively far along the transport that we got diverted from Bethesda Butler, so kept going over to Fort Hamilton. Totally good. I mean, what are you going to do in that situation? The question I might have is, we did it's again, so may have the geography right, and maybe we went west through rather than going 75 and then over. But if we're going to kind of come close to a STEMI center with a potential systems of care patient, we probably need a little bit more documentation to explain that thought process. Now, again, maybe I got the geography wrong. Maybe it was, so clearly the patient had patient preference to go to a TriHealth. And then I kind of imagine happening is that we're kind of on our way there. We're calling our pre-arrival. We learn that they're diverting us, and we're already, on our way there, heading west, and we just keep going. That is the right decision to make. But I'm wondering if we're having these conversations earlier on in the call, closer to the scene, if then, especially if we're bypassing the other hospital, if we just kind of pull off, even if we have a patient preference and a desire to go there. I'd also be kind of curious if any of the crew are there, kind of what the interaction was on the tele line, if that was something that we need to investigate further, or if it was just at capacity, move on to the next, or if there was something else that we needed to know about. So I'll open it there. I mean, those are some of my thoughts. I have one other thought though, and I think it's related to the other case that's coming up. But I don't know if any of the crews, or even if you weren't on the crew, if you can find yourself or imagine yourself in that situation, have any comments?
No, honestly, it's basically where he was headed. Somebody might be.
And sounds like it might have come from the 74s, and not sure that anyone's on, Dr. Richards.
Yeah, and that all makes sense. And we don't necessarily need to hash it. Those are just kind of curious thoughts that came to mind, but we can find that, for any situation, especially with the different options that we have. And with the receiving hospitals that we have, it really kind of all corners of the township. When we're doing that, patient preferences, well, I'll take a step back, and you guys have all heard me talk about stroke, but when we think about it, it's obviously like, we want the right level of care, the right type of hospital. We don't want to, you're not kidnapping patients, right? But you say like, hey, this is like, you need a place that can do a cardiac cath. So we're going to go to the right type of hospital for you. And then if they have a medical home, that really is the next appropriate hospital. We do have to be somewhat cognizant of transport times, but really most places in the township, it's a reasonable thing. But I do want to be cognizant, especially if that medical home, that patient preference is not available, then we're thinking about the next closest option. And if it really was kind of in the 74s area, then we have to kind of think about what that might look like, So the very last part, which I know that I've said before, but if anyone's new, because it has been actually a little while, is for these STEMIs, I really want you to have pads on. I know Hartley and the Chiefs, we might end up using pads that we may not use, but if we end up using one because we had it on a STEMI, and we're there to defibrillate like instantaneously, man, the return of spontaneous circulation for like immediate defibrillation is so high, and sometimes it is easy to get a little bit like, all right, it's chest pain, it's a STEMI, drop them off, they get their meds at the ED, they get shaved, they're upstairs. But after you'll see STEMI patients go into VFib because that's the feared complication. It happens certainly enough. This is not a rare progression of the disease process for that to happen. To have those pads in place ready to go really makes a huge difference. So that'd be the other thing I'd like to see in this situation. All right. So do we have to follow up on that one, Alex, or are we move on to the next case? I forget.
No, because it was at Kettering, so we don't have follow up on this one.
Perfect. Okay.
I can't talk to each other.
Although I think actually, if I'm not mistaken, I think that this one was an ESO, and let me just double check 3 seconds here. Hold on. I actually think this ended up, believe it or not, ended up being a non cardiac related reason. Yeah, that's right. Yeah, it was this one. Yeah, so it ended up being non-cardiac, which honestly, if we're looking at this patient in this EKG in this presentation, it is cardiac until proven otherwise. Totally fine if they want to go down a pathway and end up in that diagnosis. And for the patient, that's totally good. I guess better than having a heart attack, right? But we did all the cardiac suspicion stuff, treated as STEMI, alerted as such. Did the 12 lead. That's 100% what you do in this situation, regardless of what it ends up being. So I would not have done that any different in terms of escalation of care the way you guys did on this call.
Non-cardiac.
Thanks, Dr. Richards. I'm gonna go on to the, did you have a question?
I'm just wondering, like, how is it non-cardiac?
The question, Dr. Richards, is how is it non-cardiac? I mean, I guess if you had a prior to compare to and tropes are normal and
I think that's something that happens after they get admitted to the hospital and you get like 2 days worth of blood tests and echocardiogram. I don't think the patient actually got cath, but sometimes a cath. But yeah, it ends up being days worth of talking to a cardiologist and reassuring testing. It is not based on a 6-second 12 lead.
yeah. It doesn't look like a particularly happy heart, that's for sure. Cool. So Dr. Richards, I'm going to talk about the 5-year-old next, and then there'll be some time before we get to like the other cardiac arrest cases. So however,
cool. And no problem. And I just for the group, I apologize. So Dr. Cheatham's doing a great job of my my son has a telehealth appointment that I'm gonna have to jump off for just a couple minutes here in the middle, just to give everyone warning. And that's why we're kind of doing a little bit of stage talk here. So I appreciate everyone's patience, and I really do apologize. I have to step up just for a couple minutes in the middle. So thanks for accommodating me, Dr. Cheatham.
cool. All right. So this next case is a 5-year-old, and the dispatch was for a 5-year-old with a heart attack. On arrival, the patient was laying on the exam bed. They'd been weak for the last 2 days, but the family said otherwise they're healthy, not on any meds, but has been lethargic, and they've been giving them some tea. On your assessment, the patient was alert but slow to respond, had rapid weak pulses and a capillary refill more than 3 seconds. Got them all situated, lungs were clear, perfusing all the extremities, if not very well, but good, like pulses symmetrically everywhere. Patent airway, non-labored breathing, and that delayed cap refill. The EKG looked like VTAC with a pulse, which I don't know if people in the room or anyone else on the call wants to comment. That makes you anxious or not?
Yeah.
Makes my heart sink a little bit.
We call that March and what?
Any like immediate thoughts about what you would do?
Sync it up.
That's,
Okay, electricity?
yeah.
Yeah, it's tricky, right?
I'm assuming they're at a doctor's office, right? Like
They're at an urgent care. Yeah, not somewhere that has the ability to do anything. You brought the electricity with you. Non-labored, clear lung sounds, breathing seems okay.
Good. So,
So-
you said non-labor, you said
Yeah.
breathing seems okay, non-labor.
Yeah, so breathing's okay, mental status is like, like, we'll awake and respond to you, but maybe not like the spunky 5-year-old that you might expect, right? Like most 5-year-olds have a decent amount of energy. And capillary refill's delayed.
Yeah, treat us unstable.
Would you call that VTAC?
I would say, it is highly concerning. The frequency of VTAC in a 5-year-old is extremely low.
Kind of looks like SVT with ST elevation to me.
Okay. Yep. So SVT with aberrancy would be the more common diagnosis for like a wide complex tachycardia like this. But it's highly concerning, obviously.
Oh, yeah, for sure.
Your patient's unstable, and it is a little bit difficult to tell.
Yeah.
So that's the 12 lead. It's a little bit more helpful when you look up like this is, I don't know what to do with that.
Yeah.
You know, V6 is a little more helpful, like there's some sort of organization to this thing. Same thing up here, right? But I don't know. I don't know how to interpret this, other than not good. And I have a couple of things on my differential. So I don't expect you guys to necessarily be able to interpret this, but kind of the management part of things is what we'll talk about. So got an IV, which is great, in the right AC, which is perfect, because if you are thinking SVC, you're thinking about adenosine, then anything close to the heart is lovely. Got some fluids, had a bad blood pressure, and was tachycardic to 220s to 230s. A couple other things with SVT that can help you if this is like a super steady, like it's just the same heart rate, no matter what you do, kid gets pissed off, kid falls asleep, no matter what happens, the heart rate is just staying the same, then that can be a clue. And then this blood pressure for a 5-year-old, do you guys have like a calculation in your head or a resource that you use to figure out if this is an okay blood pressure?
It's like, what was it, patient's age plus something,
Yeah.
patient's age times something plus something.
Yeah, so 70 plus 2 times the patient's age. And I always work backwards to that calculation because a 10-year-old should have a systolic of 90, and that's when you stop doing math. And like, that's the lower limit of normal for an adult. If they're perfusing, right, is a systolic of 90. So 70 plus 2 times their age. So, that's the sort of number that you want to think about. So this kid should be at least 80 for a systolic, right? So you have a whole bunch of information here to say that this patient is unstable, which is your kind of like differentiation point, right? In any arrhythmia is, are they stable or unstable? And then we saw what the measurements look like. They contacted medical control. We're only 5 minutes away to Children's Liberty. And so they said, hold off on any kind of intervention, bring them to us and we'll take a look at them, basically. If you were 20 minutes out and this patient was unstable, conversation might be a little bit different. But a lot of kids can tolerate this for quite a while. It's been days. This kid's been in some sort of tachycardic rhythm for days. The whole time that they've been sleepy, they've probably been in this or bouncing in and out of it. So they can amazingly tolerate this for a while. So an extra 5 minutes is probably not going to be the be all end all. And it's extremely helpful for our electrophysiologists and cardiologists to have like all the data possible to diagnose these things, because this is kind of unique, kind of rare. So we talked about this, first figuring out if your patient's stable or unstable. There is a table in the pediatric dose reference section of the Southwest Ohio protocols, right at the top of that, that'll give you the same kind of like blood pressure cutoffs. It's a little bit kind of different over here, but it's around the same and at least gives you expectations for like what your peds numbers should be like. But I use that 70 plus EH times 2 pretty frequently. And again, at a certain point with kids, you have to stop calculating, right? They turn into small adults at some point, even though we don't like to admit it. So that is at the age of 10 is when you stop kind of doing the math. So this is the pediatric SVT protocol, and the kind of like inclusion criteria and what to expect is here. Usually in a under 2-year-old, the heart rate's gonna be more than 220. So I've seen infants with heart rates of 270, 280, and in older children, usually over 180. And then figuring out if they're stable or unstable, like we've talked about. And then the EKG findings, usually it's a narrow QRS and a narrow tachycardia, right? Because it's coming from the atria. And there's sort of no change. It's just the same heart rate no matter what happens. And you're going to do your basic airway stuff and assessment, and then go on to the management. So if it's a stable patient, you don't have to get permission from, I don't think you have to contact them. It doesn't specifically say, but I would probably contact and say, like, this is what I'm planning to do. Can we confirm the dose of this adenosine and kind of how to do it? But you can do all the vagal stuff right away. So if it's an infant, ice to the face, and that's ice like really covering the eyes, nose. You're not suffocating them, but like you really want to get it on most of the face. Getting an IV, you can try suctioning. These are the things that will kind of like force a little kid to vagal when they can't follow instructions for you. Or you can, if they're older, you can do, vagaling down, you can do blowing on a syringe, all that sort of stuff. And if not, then you're going to move to adenosine in a stable patient. Again, if you're 5 minutes out, they may just have you come in so that we can kind of get all the data from what their EKG looks like. I have converted someone accidentally before getting an EKG, and cardiology has gotten mad at me. So, because the EKG that I got was normal sinus, and they did not appreciate that. So they often do like to see kind of what's going on. But if you're further out, then the conversation again might be a little different. And you can start with a low dose and then double it if needed. If the patient's unstable, then that's where you just want to get on the line right away. And if you need to cardiovert, which would obviously be the type of electricity, right? This needs to be synchronized cardioversion. If you were going to do a shock, then that needs to have some sort of sedation, and the medication of choice that you guys have available to you would be Versed. And then it's only by like in conversations with medical control. So I have watched cardioversions on kids. I have never personally cardioverted a 5-year-old. I don't really ever want to do it. I don't really want you guys to ever have to do it. But if it's necessary and if it's the right thing, then obviously it's doable, it's possible. So what happened to this kid after they got to the hospital? They were ill appearing, obviously very tachycardic. They saw the same like complex tachycardia. And they were able to successfully cardiovert, and they used etomidate and fentanyl for cardioversion. So sedative and pain control. And after that, blood pressures were actually a little bit high rather than low. And this looks very, very similar, right, to the EKG that was gotten pre-hospitally. So again, maybe some signs here that it's a little bit more organized than the thing that looks like tombstones and VTAC over here. And then this was the EKG afterwards, which isn't perfectly normal, but obviously looks like a organized rhythm. And so once they got into the hospital, they had an echo that had slightly low left ventricular function, but no anatomic abnormality. And then this is directly taken from the notes, but per the subspecialty electrophysiology cardiologist, they called this an antidromic tachycardia. And
Those are available now, so.
okay, oh sweet,
The
yeah,
five are available, so.
with ventricular pre-excitation.
Well, that's not. There we go.
And then let's see. Okay,
There we go.
yeah.
There.
Resume share up there.
Okay. Right, there we, thank you.
Yeah. All right, so very long and complex kind of evaluation here, but basically ventricular pre-excitation, and a left bundle branch block, and they called this likely Mahame pathway tachycardia, which frankly I've never heard of. So this is incredibly rare. What's that?
I always look these things up when we go.
Yeah. So, basically, you guys know that SVT is because of this kind of like aberrant pathway where like the atria are firing, but it's kind of like cycling around and just making things go super fast. This is, the typical one is called orthograde, and this is an anterograde tachycardia. And so it's a little riskier. I have always gotten kind of mixed recommendations on the use of adenosine in these patients, but there are kind of reports out there that adenosine can just propagate it and put them into VTAC. And so that is especially with these ones where you can't tell if it's wide complex tachycardia because it's VTAC, or if it's a wide complex tachycardia because it's SVT with aberrancy, or this antidromic type of SVT. Those patients often get cardioverted rather than given adenosine. And again, knowing exactly what it looked like before we do any kind of treatment is extremely helpful to cardiology. So they've already been, this happened in January, they've already been back for follow-up, and have a plan to kind of just keep monitoring the echo for their cardiac function, and then maybe ablate electively at 7 years.
So it says typically if you have that, you gotta get ablation. Right? Yeah.
So it'll need ablated eventually. If she goes back into it, that'll mean she gets ablated sooner. Or if her cardiac function's abnormal, there are signs that she's like going in and out of it, then they'll ablate it sooner. I think they choose 7 just because the size of things is a little bit easier at that point. But like her EKG looks better, she's doing well. So kind of pretty impressive. This is just a reminder of the anatomy. So this orthodromic SVT, keep wanting to say SVC, but SVT kind of loops around between the atria and ventricles this way, and then antidromic kind of goes the opposite way to normal. And so the interaction with that in the ventricles is a little bit weird, and gives you this wide complex tachycardia rather than your typical narrow complex SVT. This is just an example from the literature that I found of other patients with antidromic SVT, and like their EKGs look pretty similar. You can ignore kind of the location of all this stuff. I just wanted to show you that like this does exist and it does look like VTAC. But again, VTAC is going to be incredibly rare. The problem that this patient has is already a zebra, but you know, VTAC or a true MI in a 5-year-old with no other medical history is virtually non-existent. But SVT is certainly out there, and then this is sort of like a subtype of SVT. But yeah, I feel for the guys that were on that call because I would not have wanted to see that EKG.
I'm gonna say, so the mayhem, whatever, however you pronounce it, I mean, it's not like where it's specifically, you know, PD based or adult based. It's a rare thing that can go in either one. So
Yeah.
I guess if you're talking about, let's say if this person was an adult, I mean, even after learning this, we're probably going to be assuming more of it as like a SVT or like a VTAC rather than.
Yeah,
this.
right. So usually they're gonna present when they're younger because it's gonna come up at some point. So SVT as well, right, is more common in your younger adults, like your 20-year-olds, 30-year-olds, than it is for those 56-year-olds with a known cardiac history. Like those people are gonna probably be in VTAC with pulse, and you're gonna be more comfortable cardioverting those people, right? And you'll have your 12 lead, you'll have your continuous monitoring, you'll have that to show. And they're probably gonna get if they survive, they're gonna get a cath and someone's gonna go figure some stuff out. So I would not change how you manage wide complex tachycardia in adults by any means. Just remember that under the age of 12, if you're gonna give adenosine or cardiovert, you should have a conversation with medical control, and that they're likely to tell you to do nothing unless you're way out in the sticks and the kid's like on death's door.
All right, at the end of the day, you still need to be cardioverted.
Yeah.
So think about that.
So cardioversion is still the answer, and cardioversion is the answer for unstable SVT, right? So whether it's wide complex or narrow complex, if you're unstable, then technically cardioversion is the answer. We try adenosine often in kids with unstable SVT, I think probably because like at children's, because we don't use electricity very often.
I don't wanna shout.
So we, you know, and we have them right in front of us and we can watch and see what's going on and change our minds at any moment. But the answer to an unstable patient with a wide complex tachycardia is cardioversion. They have a pulse.
Right. Like you said.
Step one, pulse, no pulse, and then go down from there.
Right, so
Yeah.
you saying adenosine, and you're saying under 12, make a call.
Yeah.
We talking about cardioversion, pretty much we talking about regardless, we see that on the child, make a call.
Yeah, don't do it yourself.
Just make a call
Yeah,
before
I mean, I'm calling 5 people too.
Yeah.
I'm running to the bathroom and then I'm calling 5 people. Even sitting in the children's, and especially at Liberty, actually, yeah.
I know that.
It's clean up on aisle 1 for sure. But yeah, so this, again, back to this patient's EKG, I mean, it's tough to pick apart, especially if you're getting, you know, just your 3 lead. Once you get the 12 lead, you can get a little bit more information, but it's not your job to fully interpret this, right? Like you have patient in front of you, you have options for what you can do, but you're gonna get on the line and get some help, for sure. Cool. Yeah, not enjoyable. Okay. So we're gonna go through a couple cases of cardiac arrest today, and I just want to start it with like sort of an overview and introduction about high quality CPR, just as a reminder to everyone for stuff that they probably already know, but is worth kind of talking about with some degree of frequency. And full transparency, I've not been on a cardiac arrest run with one of you guys yet, so I haven't seen kind of how it goes with this department, but we'll just talk through kind of like standard metrics and that sort of stuff. So you all know this, high quality CPR, you need a good rate, a good depth of compressions, you want full recoil between compressions so that you can allow the blood vessels of the heart to actually fill, right? They fill when the chest is relaxed. And you want to minimize interruptions in chest compressions and avoid excessive ventilation. And that's kind of like the hallmarks of high quality CPR. When we think about metrics and like what we can actually look at numbers wise, there's a couple of things that we want to accomplish. The first is to start manual CPR and have the monitor on before you get the Lucas on, right? The Lucas is super helpful, but if you have a shockable rhythm and you're waiting 2-3 minutes to get the Lucas on when you get the monitor on, you've, you know, already missed, like Dr. Richards said, like the sooner we defibrillate those patients, the better. So try and get that monitor on while you're doing manual compressions and then figure out getting the device on. You guys can do good manual compressions. You can do it. Yeah.
Going back, this is the 4, going back to that. Children's cannot receive EKGs from us, so I would say 99% of the time they're gonna tell you to do nothing anyways.
Yep.
I just wanted to let everyone know that.
I appreciate that. Thank you.
That children don't receive 12.
Yeah. And I think, again, if you're 20-25 minutes out and you're describing a patient that is like really on the edge, right? Then it might be a different conversation. I know Dr. Schwartz, who's one of the pediatric medical director for CFD, has walked a squad through synchronized cardioversion in a kid once before, and his career has been longer than mine. So it's an extremely rare event, but you know, potentially not a never situation. And if that happens, you know, you give us the information that you can, and cardiology has to deal with it. But yeah, more likely than not, I think people are going to tell you to hold off. Thanks for that. I appreciate it. Okay, so back to these metrics. So again, getting the monitor on, starting manual CPR before you get the Lucas on. The CPR fraction is basically the amount of time spent during CPR compared to the amount of time off the chest. And there's some debate about kind of like really what this number means. But at the moment we have this goal of kind of more than 80%, which really just tells me that you're minimizing time between compressions, time off the chest between compressions. Your compression rate, you want a goal of 100 to 120. You can sing whatever song you want to in your head while you're doing manual compressions. There's no judgment. The Lucas is set to 102, so we can always tell kind of like when the Lucas is going. And then you want to limit pauses to less than 10 seconds. I think generally, rhythm checks / pulse checks are brief. There's often a lot more time when it comes to like any patient that needs to be moved, if they're in a tight space, if they're awkwardly positioned, and then actually time getting the Lucas on. So it's worthwhile kind of thinking through and planning as a group and communicating like, how are you going to get the Lucas on, or how are you going to move this patient, just to limit that time off the chest. Rhythm checks every 2 minutes. And again, the point of that is that you identify a shockable rhythm as soon as you can, and intervene when possible. And then getting access, IV access is great if you can get it. If you can't, humoral IO is going to have good flow rates. It's close to the heart. You're going to get meds in really well. And if you can't, then in the leg is acceptable as well. And then you guys do a great job of this, even on just generally sick patients, but end-tidal CO2 monitoring is really critical and can actually help you with your decision-making and your troubleshooting as you go through. This is a diagram that shows kind of the concept of compression fraction. So basically each one of these upstrokes is a compression, up, down. And when you pause, you basically lose the pressure that you've built up, and you have to start back up and get to the point where you're actually perfusing. So that's why continuous compressions are great, and why you want to limit your time off the chest so that you don't have this like huge lull between compressions. And then when it comes to ventilations, obviously different ways to manage the airway. If you are bagging, then you're going to be doing 30 to 2. If you have an LMA or intubated, then continuous compressions. You want to ventilate slowly over a second, and avoid excessive ventilation. So you're aiming for 10 a minute, which is 1 every 6 to 7 seconds. This is hard for me because I'm used to ventilating every 3 seconds, but it takes kind of like slowing yourself down, taking a deep breath, and kind of paying attention. And it's, task saturating, right? If you're there at the head of the bed, you're not necessarily going to be thinking about a whole bunch of other stuff, especially as you're getting started. You're going to be focusing on that airway and focusing on what you're doing. And you know that you're giving good ventilations. If you see chest rise, it's tricky if someone's busy pounding on the chest, right? And that's where your end tidal comes into play. So using end tidal to actually see that you're getting a rise in your end tidal with each breath. And then you can use the actual number to help with some other decision making. So this is kind of like what's happening with end tidal, just to give you guys the physiology behind it. So end tidal is the expired carbon dioxide, right? So in the first phase down here, there's no CO2 that's made. That's just your big airways. So that's the air coming out of your trachea and your big bronchus, parts of your airways that don't even participate in gas exchange. So it's basically just ambient air that sits there and fills up those airways. So there's no carbon dioxide there. The second phase is when you start to see parts of the lung that are like given a little bit of ventilation. And then the third phase is the air that was sitting in those tiny little air sacs in the alveoli that actually participated in gas exchange, and the carbon dioxide is being kind of expelled out of those. And then the last phase is when you stop exhaling. So you're going to give a breath, you're going to let go of the bag, and then it's going to take a second before you start to see some of that carbon dioxide start to be released. And this is where capnography can really help you. So if you are doing effective, high quality CPR, you're typically going to get values over 20. There are certainly situations where you're not going to get to that point. But if you're not at 20 or higher, then if you're doing manual compressions, maybe someone's getting tired. If they're on the Lucas, maybe the Lucas is slid up or down to where it's not actually like compressing over the heart directly. There might be some other part of this that means that you're not, or your ventilations aren't effective, to where you're not getting good end tidal. So troubleshoot it and think about it if the number is under 20. When patients have ROSC, there's usually a sudden increase in end tidal, and I think people are pretty good at noticing that. Just because the number kind of peaks up, you don't necessarily want to stop compressions unless that person starts kind of punching and fighting you off. Just finish out the cycle and do your pulse check at the end of your 2 minutes. And then if there is an issue with your airway, you're going to see a drop in end tidal. So you can look at the waveform, but also look at the numbers to really help you troubleshoot kind of what is going on. If you're not getting good end titles and you have what you think is an appropriate airway, then you can troubleshoot the airway as well, right? Is it the correctly sized LMA? Is it a little too big, a little too small? If you have an endotracheal tube and you're not getting good end tidal, then that tube is not in the right place. It's in the esophagus, it's too high, it's the wrong size, something else is going on. Okay. This is just a reminder about humeral IOs. Do you guys like to go to the humerus right away? Or do you try the leg first? Definitely the leg. Yeah, the real estate is tough.
I went
Right.
for as my last one.
Yeah, it's a good place. It is, you know, the space can sometimes be tricky. And then like moving that patient's arm when you go to put it on the Lucas, you do need to be careful and you do need to kind of troubleshoot and make sure it's still in the right place. But it is a good spot to go. I'll show this video since you guys aren't like routinely doing it. I'll show the video. But if someone's like laying on their back, you're kind of a little bit in front of that like flat line going in at a 45-degree angle and kind of like aiming down. So it is a little bit, the anatomy of it is a little bit trickier than the tibia from my perspective, but once you get it figured out, it is actually really a great spot. So let's let this guy hopefully talk us through. There is another video where they actually put it in this alive human and he doesn't flinch. This is not that video. This is just him talking.
If he's talking, we can't hear it.
Oh, of course. I didn't share the sound. Let's see. Again, thank you guys.
If I was talking.
Let me know if it's better, okay?
It was really hurt until they pushed through it.
It's better.
I will be demonstrating the proper insertion of an intraosseous needle in the proximal humerus. Proximal humerus has many benefits, one of which is it's a large target. And just to appreciate how anterior to the midline the proximal humerus lies, one can take the palm of your hand and actually palpate the anterior portion of the proximal humerus with the palm of your hand. The patient's hand should be placed over the abdomen in order to help internally rotate the humerus to keep the intertubercular groove, which is where the biceps tendon is, medially and out of your field. The site of insertion is the greater tubercle, which is on the anterolateral aspect of the upper arm. In order to find the proper landmarks, I'm going to go over some techniques that you can use in order to feel the proper bony anatomy. The first thing that should be done with the patient's hand over the abdomen and the elbow tucked in and the arm adducted against the body, one should place the ulnar aspect of the left hand, in this case, in the axilla to help define the anterior border and keep myself out of the medial aspect of the arm, which is where the brachial plexus resides. The other hand should be placed in a perpendicular fashion in the midline of the upper arm, and where my thumbs will come together will define a line over which I should be palpating to feel for the surgical neck. The proper target is about 1 or 2 centimeters or 1 finger breadth above the surgical neck. So I'm using my hands in order to define where along the upper arm I should palpate, and palpating up and down I will feel for the surgical neck. It will feel like a golf ball on a tee. Where the golf ball meets the tee, that's the surgical neck. The proper placement is approximately 1 or 2 centimeters or approximately 1 finger breadth above that. So I've determined my landmarks. I'm eyeballing where I believe I'm going to be putting the needle. And I want to make sure I'm putting the needle at approximately a 45-degree angle, and I'm flush and perpendicular with the plane of the skin at that insertion point.
So again, so this is the golf ball on a tee that he's talking about. So basically this ball that's the top of your humerus, the surgical neck is that kind of skinny part right underneath it. And you really are going to be, you know, anterior to like the plane of the floor, wherever this person's laying down, and then slightly angled downward. So that's kind of the angle that you need to be thinking about if you're doing a humeral IO. Obviously, if you are doing CPR, you can't necessarily have the person's hand over their abdomen, or if you have a pregnant person, you can't necessarily manage that. So you can have them put their, or not have them, move their arm for them, because this patient's not alive at the moment, and put the arm at the patient's side and then put the thumb down. And that has the same effect of internally rotating their shoulder. So basically, thumb down toward the floor, whatever surface this patient's on, with the arm at the side. And then when you need to move the arm and kind of attach to the Lucas device, just, move carefully, and recheck your placement, when you're there by aspirating. But it does have, some benefits to it. First, kind of being close to the heart, but also the, flush rates, at the humeral IO are a little bit faster. So you may find that fluids go in better there than they do in a tibial IO, especially when it's just to gravity. This is just a, like X-ray of what it looks like when they infuse some radio opaque stuff. So this kind of overlying here, right, surgical neck, top of the humerus with the IO in here. And when they put that dye in, you can see it pretty much immediately getting into the subclavian and then getting to the heart pretty quickly. So coming right through here, and then it's going to get into the heart, in 5-10 pumps rather than whatever it's going to take to get up from the leg. And CPR is a low flow state anyway. And so regardless, things are going to take longer to kind of move around. So the humerus might give you a little bit better bang for your buck. Do you guys have questions about humeral IOs? Always use the yellow one. The other ones may not be long enough to kind of get through the soft tissue of the side of the arm. So always use the yellow needle. Think about that anatomy. Feel free to palpate on each other with your partner's consent, and kind of find that, figure it out, kind of move your arm in and out and see what it feels like as you kind of move around. All right, cool. So a couple other sort of like tips or things to think about. Again, this all comes back to the fact that if someone has a shockable rhythm and we can defib them quickly, then that has the best chance of saving someone's life. So that's why getting pads on while you're doing manual CPR before you even get the Lucas on and figuring out what the rhythm is early is helpful. But also it's why we would sort of lean toward you defibbing. If there's anyone in the room that thinks something should be shocked, you should probably shock it. And you should probably take some communication
Every time.
But if there's, the other way of thinking of this is if you're not going to shock, have two people agree to not shock. So have more than one person looking at it. And if there's any thought of like, yeah, this might be defib, like it's a little bouncy, it's a little weird. Yeah, just shock it. If there's a decision to not shock because it's PEA or asystole, then two people should be able to say like, yep, I agree, this is PEA, it's bradycardic, there's no pulse, or it's totally flatline, I agree, and we're not going to. And when we talk about pulse checks historically, like we're sort of trying to move to a language to talk about rhythm checks, because the rhythm is really what is the only thing you can intervene on, right? Like epi is epi, amio is amio, fluids, bicarb, calcium, like the data is like different and neither here nor there for some of those, but shocking saves lives. So that's kind of where we want to focus. And this is like a coordinated dance, right? So it's not, everyone's hanging out, we're just letting the Lucas do its job, right? It really is coordinated and takes communication on everyone's part. So make sure someone's on a timer, thinking about pausing the Lucas every 2 minutes, but it's not just stop the Lucas and like, oh, by the way, we're going to do a pulse check, right? Someone has their finger on the pulse before you stop compressions, so you know where you're palpating, right? I don't like working with big humans for a lot of different reasons. I like the little ones, but like I have trouble finding the pulse on like an obese 60-year-old. I struggle, and like I should be like, I've been doing this for a while, right? You guys have been doing this for a while. We should be able to find a femoral pulse or a carotid pulse on a human being, right? But if you're like fumbling around trying to look for it, like, well, is there a pulse? Isn't there a pulse? You don't know. So whoever is on pulse checks, right? If it's the least experienced person, consider having another person double check, right? It's a hard thing to do as the least experienced person there. But have the finger on the pulse during compressions, because you should be able to feel it. Then you can find it. Then when you pause the Lucas or the person who's doing compression stops, now you know you're in the right place. And if you don't feel something, you don't feel something, rather than like, oh, well, I don't know. We're still trying to figure out where we are, what our landmarks are in, an obese human being. So get your finger on the pulse, and before the person who is going to say, time to stop the Lucas actually stops the Lucas, pre-charge the monitor, especially before the first check, maybe the second check. After that, if you've been in asystole or PEA for 2-3 checks, like, I'm not going to fault you for not charging for every one, but especially like right as you're getting started, consider pre-charging and expect to shock the patient. And if you don't, well, then you just dump it, right? And if you accidentally don't dump it, you haven't really done any harm, but try and dump it. But pre-charge the monitor. And if you don't, and you find that it is a shockable rhythm, get back on the chest, restart the Lucas right away while you're charging. Again, the point of this is all to limit time off the chest, limit time where we're not perfusing, and try and get these, the time off the chest to less than 10 seconds. So that's kind of little things. And then final, this is a little bit of soapbox for me. I've heard stories, I've seen cases where, not necessarily from here, again, I haven't run with you guys on a cardiac arrest, but where people have taken either a teeny tiny little old lady or a little bit of a small teenage sized human, and kind of propped them up because the Lucas wasn't fitting, right? For an obese person, there's no way to like maneuver that and get the Lucas to fit. But I have seen people like putting blankets, putting pillows, like trying to get that tiny little person up to the device and up to the suction cup. It's a total no-no. All right, like you cannot do anything at all to modify the Lucas device. So don't put anything behind that patient's back. Don't prop them up. Don't, add anything. This is directly from the Lucas manual, but it makes sense as well. It's a nice thing to have. It makes you guys, doing CPR while you're riding in the back of the ambulance, if you can do it with a Lucas, infinitely safer. Love it, right? It is effective. It's not proven to be more effective than manual CPR, so you can still do good manual CPR. And if the device doesn't fit the patient, it doesn't work, and it's not safe. So just don't do anything. And again, this is like stuff that I've heard and seen, which is why I'm on a little bit of a soapbox about it. But just be thoughtful and cautious, or if someone, young guys like, oh, well, they're almost there. Like, what if we just stick this towel under them? Like, absolutely not, right? And again, if they're too large, there's no real way to like make it work. So I don't think that would ever be a problem.
Bungee cord, right?
Yeah. Bungee cord, just like manipulate the wires inside so that actually, yeah.
Ratchets.
I mean, I would use one of them sturdy ones they use on there. Not the whole people, the big black sturdy one.
The crank, or like the crank thing. Yeah, okay. All right, the summary is don't do anything to modify the Lucas. all joking aside. And again, like it's taken straight from the manufacturer, but also makes a lot of sense. And then I didn't necessarily give you guys any kind of like protocol talk in terms of the updates for 2024, but you do carry calcium, right? And I think was that
Yellow, they're the lemonades. That's
Yellow,
what they're-
yellow.
They look like the lemonades, Girl Scout cookies.
Oh, nice. So I think people were already doing this before, but the 2024 protocol was officially updated to include calcium for specific things. So basically when it comes to cardiac arrest, and that's all I'm going to talk about here, but when it comes to cardiac arrest, it's someone who is in cardiac arrest, and you suspect that the arrest might be due to some sort of hyperkalemia, so a high potassium level. Basically, that's your renal failure and stage renal disease patients on dialysis. So, hey, we're here for grandma, we're doing CPR. Daughter comes in, chimes in like, oh man, such a bummer, she missed dialysis yesterday. All right, that should tweak you and make you think about giving calcium. It doesn't directly affect the potassium level, but it helps to sort of stabilize the heart's membrane potential, like how those impulses work and happen in the heart, to kind of help the heart be a little bit happier. but recognize you're not actually doing anything for the potassium level itself. You're just making the heart a little bit happier. And then there are two types of calcium. I suspect you guys have calcium chloride, which is really what we use for arrest or like high acuity situations. And basically the dose is 1 gram. Recognize that it does have a risk of necrosis if it extravasates. So for some reason you get ROSC on this patient, but you notice that your IV extravasated and you'd given calcium through that, like please inform the receiving hospital. It happens and that's fine, but it's helpful to know. You can run it through an IO and that's fine. And then calcium gluconate is a different form and it's totally different dosing. So if for some reason there's ever a time where there's a shortage or things change, just be aware that there are 2 different forms, but you guys are going to be on this side of calcium chloride, basically 1 gram of calcium chloride for your cardiac arrest patients, where you suspect some sort of high potassium as contributing to the cause of their arrest. All right, so that's my pearls and my little soapbox. So thanks for putting up with that. So now we're going to go into a couple of cases. So this first one is a 32-year-old female reported to not be breathing. She was found lying on the floor, pulseless and apneic, and the police officer started doing CPR. Awesome. The partner said that she had woken up to the patient shaking, and the hands were in like sort of clenched in a fist. Patient stopped shaking, and the partner called 911. It was a little difficult kind of maneuvering in the area. So it's helpful to have people kind of note that that was a contributing factor, but getting manual CPR started and then getting the patient on the Lucas, initially with a bag, and then pads were placed. We detected BFib and shocked the patient with conversion. They got back on the chest, right, which is what you want to do. So after you shock, just get back on the chest, finish out the next 2 minutes and reassess. And after that, the patient started having agonal breathing and had a weak pulse and a blood pressure of 155 over 135 after ROSC. They did end up getting an iGel. We're not able to, I think this one, we're not able to intubate due to the patient's anatomy. But they had an IO, they were able to pull back and flush easily, gave 2 rounds of epi, a bunch of fluids, and the iGel, and used capnography. So a good example of kind of why we want to get pads on early. In this case, the pads did go on by the time the Lucas was already running. So there was a period of time where we might have been able to get there a little bit sooner. But obviously it's very helpful again to have documented like the situation of the room and kind of the limitations of the environment, which are unique to, practicing in people's homes and workplaces and all that kind of stuff. So this is what the rhythm looked like before the shock here on the left. So definitely agree that looks like BFib. And then after the shock, not super interesting or impressive. But did I have, and then I don't have an EKG. So that's what the patient looked like. I want to kind of show you guys what we can see from the monitor perspective to kind of walk you through what we can figure out and what we can tell and kind of maybe help give some more feedback on this case. So this was just part of the kind of time period for this patient's care. Each of the blue triangles is a breath. So all of these is when the end tidal is picking up a breath, and all of the red lines are individual compressions. And that's on the side here, compression rate. So the Lucas was on this whole time. Again, there was like a brief moment before the Lucas went on where maybe it wasn't a rate of 102. You can see we're at 9 minutes here. But it does look like the monitor went on basically as or just after the Lucas was placed. So get those pads on, get the monitor on, keep doing manual CPR, and then worry about getting the Lucas on, because the Lucas is not going to fix the patient. The electricity might fix the patient. And then every once in a while, if you count kind of each of these horizontal bars here is 1 minute, so 9 minutes, 10 minutes, 11 minutes. So counting the ventilations, sort of an average of like 12 ventilations a minute, which isn't bad. We're aiming for 10. So just a reminder, as you ventilate, if you're hyperventilating the patient's chest and putting more pressure inside the chest, you might actually be decreasing the return of blood to the heart, and kind of shooting yourself in the foot in a way in terms of not necessarily helping with that blood flow. So that's why we're aiming for ventilations of about 10 a minute, but generally like really nicely well spaced, and not 20 a minute, which is great. So think about the timing of that, focus on, if you're the one at the head of the bed, focus on that task, and kind of how long you're giving that breath and how often you're giving those breaths. And then, with this monitor file, we can tell that CPR went on for a little while longer before like the next full pulse check. And I don't know, what might have been happening here, having to move the patient more, being distracted with other tasks, trying to manage the airway, getting the meds on board, all that sort of stuff. So just be aware, again, this is a coordinated dance. It takes a lot of communication between everyone to kind of do these resuscitations in like a crisp timed way. And it's tricky. So that's kind of the only feedback I had here, but I think, overall getting this patient to the point of having ROSC is fantastic. And we can talk about kind of the priorities and post-ROSC care a little bit. But for a patient who's in VFib or pulseless VTAC, high quality CPR and defibrillation are your first two go-tos, right? And again, manual CPR first, get the pads on first, and then figure out if you need to defib. And then epi is your first drug of choice. You also have amiodarone available as an antiarrhythmic. And I wanted to see, Dr. Richards, what your thoughts were about giving amio for a patient who was in VFib or pulseless VTAC, who has converted and now has like stable blood pressure. Because I don't really know the benefit of that. Certainly if you're going multiple rounds and shocking repeatedly, definitely pull the amio out. It wasn't given in this case because the patient had ROSC by the next pulse check. So I wasn't sure what your thoughts were on the amio.
Yeah, I think you're probably justified either way. I mean, it's not like rock solid, like evidence behind it. A lot of the time, like you said, especially like in the refractory, so you're kind of throwing kitchen sink, and especially if you're kind of worried about kind of like unstable myocardium and all the rest, especially afterwards. So, I think you're well justified. I think many would. If you wanted to hold off and defer, it's probably not an unreasonable thing either. But probably on the balance, it's it feels like we're doing something, and you're potentially helping in these situations. It's probably something that I would do, just to put it on. But if you kind of end up defibrillating, getting ROSC back, and you end up not getting it on, there's definitely higher priorities on scene. So I think you're well justified either way. Or if you have extra hands, somehow probably would end up doing myself.
If you think about it and you have the manpower, then worth going ahead and doing it.
Yeah.
And then the final thing is bicarb, which again probably would not have made a difference or make a difference for this case. But if you're running through an arrest and kind of doing multiple shocks, giving multiple rounds of epi, then thinking about bicarb because that patient's probably acidotic is reasonable. And then the final things for this patient, we'll talk about ROSC and kind of what to do and what to think about. So the statistics on this, I mean, we got ROSC on this patient. We only get ROSC in about 30% of patients treated by EMS for out-of-hospital cardiac arrest, and a high percentage, almost half those patients rearrest. So the take-home point for a patient who you get ROSC on is expect them to rearrest. Check on them, monitor them, pay attention to them in a way such that you can detect that and act on it again. And usually it happens within like 3 to 5 minutes. So that's probably while you're trying to like move and negotiate and get the person situated to transport, and there's a lot of other things going on. So just remember that a lot of your patients who you get ROSC on are going to rearrest, and they're going to rearrest fairly soon. But definitely pay close attention and reassess them kind of continuously throughout transport. And about half of the patients that rearrest get to hospital survival. So obviously the more times you arrest, the less chance you have of surviving in general. But that's just the data on ROSC. And in terms of our management and protocol for patients who get ROSC, the first is kind of look and treat any possible causes of the cardiac arrest. So again, we have few things that we can do, but if they have asymmetric lung sounds and you think tension pneumo was the cause, trauma or not trauma, if you think that they had hyperkalemia because they're a dialysis patient, you can, do calcium. So there's we have a couple of things that you can do in terms of treating the typical H's and T's of cardiac arrest. You're giving fluids to address any hypovolemia, you're giving them oxygen, managing their airway for any hypoxia. So all of those things are things to think about. And then we do want to get a 12 lead on all of these patients. And that is, again, one thing that was not obtained or that I didn't see for this patient. And really that's because there's only a couple of things that the hospital, well, I guess I shouldn't say that. I'm not giving Dr. Richards enough credit. There are several things that the hospital could do, but there's really two main interventions for a post-cardiac arrest patient. And that is, was it the heart? Fix it. And try and avoid any further neurologic damage with like targeted temperature management. And those are like the main things that can be done kind of immediately post-ROSC. And that's why your 12 lead is important if you're making the decision about, potentially going to a non-STEMI capable center. Maintaining their airway, keeping them breathing, keep the pads on, right? So again, this is because that patient who was in arrest, who gets ROSC, has a high chance of rearresting. And this goes back again to one of Dr. Richards' initial comments and will come up in the next case as well. But having those pads on means that you can intervene if the patient flips back into a shockable rhythm. When I ride with these patients, I just sit there with my finger on the pulse. Also, I'm an extra person, so it's great. I have nothing else to do, so I can just sit there and do that. So that's not particularly helpful, but you're bringing an extra person in the back of the ambulance for these cases anyway, right? Someone's on the monitor, someone's on the airway. Pay close attention to that patient's mental status, their tone. If you can keep a finger on the pulse, again, it means you can find it easily at some point later, if necessary. But just be aware that this patient is high risk for decompensating. And then this patient was not hypotensive after the fact. They were like 150s systolic, but get ready to pull up some push dose epi. And if you need to, give a cc of a milliliter of push dose epi to help with the hypotension of the bradycardia post arrest. Again, as long as there's a pulse, right? Like if they're in a organized rhythm and a little bradycardic, a little hypotensive, they may be circling the drain. This may actually be PEA. So check, make sure you got a pulse. If you do, use your push dose epi to help maintain that blood pressure and that heart rate. Again, the two things that the hospital can do is take a patient to PCI immediately if it's a cardiac cause and there's a blockage, or do targeted temperature management for patients who are not responsive after cardiac arrest. And so this patient actually did get targeted temperature management after her admission. The challenge is that rewarming a patient is pretty risky. And so she did go into status epilepticus when she was being rewarmed, needed a whole bunch of anti-epileptic meds for that, and ended up being transferred downtown. And unfortunately seems to have pretty significant hypoxic ischemic injury and neurologic sequelae from this, but is still full code and now is at like an LTAC. So not a great outcome. You got her to the hospital. She got the management that she needed, but again, even in that 30% of patients where you're going to get ROSC, the outcomes are not always going to be great. All right, the next one was actually a patient who arrested in front of you guys, which again, these are all these cases today are ones that kind of get your heart rate going, make you nervous. But this was a 69-year-old female, fell in the bathroom and was kind of on her head. Family member called. She said she hit her head, but that part of the exam was okay, no deformities or anything. At that point, she was alert and oriented, had a patent airway, breathing a little labored, but her oxygen had come out, so got her oxygen back on her. Good pulsers, good perfusion, and started kind of getting the patient out. Got vitals, got the first EKG, got the patient on capnography, which is fantastic. Again, it's a great measure of really a lot of what that patient is going to be able to, is what they're going to be doing in terms of their respiratory drive, their circulation. And after getting the 12 lead, the patient started having agonal respirations, started bagging with a bag valve mask, and then the patient stopped responding, kind of went limp. Pulses were checked, and she didn't have a pulse, so CPR was started. The pads were placed, patient was found to be in PEA, and then got the Lucas on, continued back, and pulled into Westchester. So this is the patient's first EKG before she coded. And again, concerning for MI, remarkably similar in some ways to that other patient's EKG. And this is where Dr. Richards' comment about getting all these STEMI patients on pads is kind of key, because it was probably about 2 or 3 minutes between when it seemed like the patient went into PEA and when the monitor was on and kind of picked that up. And that couple of minutes, if that's a shockable rhythm and you can intervene even within that time period, your chance of saving that patient is going to be way higher. So get the pads on. If you don't want to plug them in while you're kind of maneuvering and all this sort of stuff with all those cables, you can always put them on and then plug them on as soon as you're in a position to actually get the monitor connected. Because I know it's a lot of different things to kind of orchestrate as you're trying to extricate someone out of their house. But this is a situation where in a patient with an MI, having the pads on could be life-saving. She was not in a shockable rhythm. This was, I think, the point at which she went into PEA. But you had end tidal on with an end tidal of the 40s. So that number might have been able to help clue you in as well, right? If she had been 25, 30, now she's had a rhythm change, end tidal's creeping up. She's not responsive anymore. These are all just clues, pieces of the puzzle to help clue you into something having changed in her clinical status. And again, 2-3 minutes until she had the pads on and everything. So get those pads on for your STEMI patients. If you get ROSC, expect them to rearrest, keep the pads on. And I think that's the take home from these 2 cases. Anything else to add, Dr. Richards?
No, I agree with you in terms of the high points.
Any questions about cardiac arrest? There's obviously a lot more we could talk about, but.
Right, that's what I'm saying. So basically, what we're talking about is that she didn't have a shockable rhythm because she went to PEA while they were in transport. So basically at that point, they're pretty much like, she coded, here we come.
Yeah, it looks like they were like literally in the back of the medic unit, right? And at that point, it's a witness arrest. She's 69. But someone who arrests that you guys witnessed who is young could be a candidate for ECPR or like ECMO CPR basically. And so this isn't someone who I would stop and be like, oh, let's finish working the 30 minutes on the scene. Like you saw her alive and talking to you. She arrested in front of you. You're basically on the way to going, just take this patient rather than continuing to work on scene. There's a ton of value, right, for an unwitnessed arrest or someone who just went down and the family saw him 5-10 minutes ago, to you guys working on the scene, right? Like we've pushed that way harder than just the scoop and run that we used to do, because you are effective at managing these things on the scene. But for this patient where you were the one that watched them go down and you have the information that you have, even though it's not shockable and it's PEA, that's someone that I would take in. And I think Dr. Richards, hopefully you agree with that.
Yeah, if you're pulling off towers, well, you just keep going. I mean, do compressions.
Yeah, keep doing the things that you would do on scene, but yeah, just bring them in. And Westchester can or can't do ECPR, Dr. Richards?
Not ECPR.
Okay. Will they put people on ECMO upstairs and then move them?
I've had that conversation recently, and I honestly I forget what the upshot was. Uh, my thought is kind of not, but I actually don't know that that's 100% true. So we'd have to follow up on that. That's a good question.
Yeah. So ECPR is basically, do you guys know what ECMO is? You're cannulating a gigantic vein and or artery, and basically circulating the patient's blood volume for them. So you're taking over the function of their heart by circulating the blood, and you're taking over the function of their lungs by oxygenating that blood as you circulate it. So it's, you know, sort of a kind of bypass-esque, but it's just with a, you know, gigantic cannulas in the neck. And there's, I don't know if it, not many people survive if you do ECPR, which is basically ECMO in conjunction with a resuscitation. But for witnessed non-traumatic arrests in healthy young people, those are the people that most centers I think would consider as candidates for ECPR. So people would probably ask those questions to you, right? Like, what's the patient's age? What's their medical history? Any chance this could have been trauma? And like, what have you done so far? So just to have in your mind of, you know, I said targeted temperature management and PCI are the main interventions. There is that other little tiny bucket of patients who may be candidates for this very resource intensive, very unique treatment if they're getting active CPR. But that's why if it happens right in front of you and you're already in the back of the unit, just go. Cool. We're close to time, so I'm going to touch on a couple of other cases just very quickly. This was a 21-year-old who was found with altered mental status, pinpoint pupils, had been normal like 15 minutes before that, but had been given someone else in the family's Plavix and aspirin at that point. When folks got there, she was tachycardic to the 150s, hypotensive, and there was sort of the suspicion of, was this allergic reaction? Was this opioid overdose? And so gave Benadryl IM as well as Narcan, neither of which, and some fluids, neither of which did very much. And just a reminder, like young person with altered mental status, long differential of things. Obviously, if you have pinpoint pupils, then an opioid overdose is going to be high on the list. Any other sort of ingestion is on there as well. I think any kind of shock state is good to think about. So anaphylactic shock, hypovolemic, septic, hemorrhagic shock, right? 21-year-old could have had like a ruptured ectopic pregnancy and be in hemorrhagic shock. Obviously, usually I have some belly pain kind of leading up to that, but there are non-traumatic reasons why a young woman might be in hemorrhagic shock. Stroke, intracranial bleeds, seizures, and then kind of this other bucket of stuff in terms of respiratory and electrolyte abnormalities. So definitely agree with the Narcan. They did wait to put an IV in this patient, so just remember you have intranasal as an option. And then if you have anaphylaxis at the top of your list, and especially if that patient looks like they're in shock, then I would move pretty quickly to IM epi. I often see Benadryl as kind of like the first go-to when it comes to anaphylaxis. But if you're highly suspicious, that patient has hypotension, vomiting, difficulty breathing, any of the things that kind of fit into the bucket of anaphylaxis, and they're hemodynamically unstable, then definitely think about IM epi. And then the other things for this patient would be grabbing a blood glucose, which I didn't see documented, and an EKG to help you differentiate the couple of things that you can act on. This patient ended up having probably multi-drug ingestion with some acetaminophen, some fentanyl, some tricyclic antidepressants, and ended up needing intubation in the ER and kind of management for all those things, and did recover okay from what I can tell. So complex sort of situation. Again, you're looking for the couple of things that you can act on quickly. And if anaphylaxis is crossing your mind, the next thing that should pop up is, does this patient need IM epi? Okay. You can do the Benadryl later, but the first thing should be the IMAP. And then this last one again, because you're dealing with a pediatrician, is this 3-year-old who had a seizure. And I just thought this was interesting because you probably see loads of patients with febrile seizures who have stopped and are either a little postictal, a little sleepy, or have like basically come back to normal by the time you get there. And this patient kind of bucked that trend a little bit. So had a 3-minute seizure, but then seized again while in a medical office, and then seized again while en route with you guys. So this patient, even though none of the seizures were more than 5 minutes, they were not returning to baseline in between and were having multiple. And so giving Versed is absolutely reasonable for those patients. So this patient got 2 doses about like 10 or 12 minutes apart, which is fine. If it had been 3-4 minutes, that's probably too close. But 5:43 and 5:54, that's a reasonable time between, especially since the patient seized in the middle. Got a glucose, which is excellent, and it was high rather than low. And then this patient's hospital course, they got everything. So labs, CT scan, and a spinal tap and antibiotics and admission. So very different from your typical 2-3-year-old who has just a short febrile seizure and never seizes again, comes back to baseline. We still monitor those patients, but we don't necessarily have to do all this stuff. But this patient was a lot sicker and ended up being treated as sinusitis, and thankfully did not have anything actually inside the brain or inside the spinal fluid. So your priorities from a pre-hospital perspective: airway. You want to make sure that the airway is patent. You want to support their breathing either in the midst of the seizure or after you give Versed. These patients are super high risk for hypoventilation, both while they're seizing and then after you treat the seizure with the benzo. So that is the main thing to pay attention to. If you don't have concerns of trauma, you can put them on their side. And then the indications for Versed, the first is if they're still seizing by the time you get there, the assumption is it's been more than 5 minutes. Like, you guys are quick, but probably not that quick necessarily to get everywhere. So the assumption is that seizure has been going on more than 5 minutes, and so that's an indication. Or if the patient has a seizure lasting more than 5 minutes in front of you. In the ER, we get excited after 2 minutes and we start pulling up meds, and I think half the time we scare patients. But really 5 minutes is what you're looking for. And then it's not technically in the protocol, but if the patient's clustering, having multiple seizures, not coming back to baseline, then giving Versed is reasonable. Checking the glucose, which they did. And if you're the ones witnessing the seizures, there's a chance this kid doesn't seize again. He did, but there's a chance you're the only ones who have seen that. And so taking note of what it really looks like, especially paying attention to any kind of focal features, is very helpful, because a simple febrile seizure, there's simple and complex, is for a simple one, it has to be a generalized seizure. It has to last less than 5 minutes, and there has to only be one of them. So if there are any focal features, that changes what I'm going to do in the ER drastically. Okay. So if you notice, if you pick up their eyelids and they're only looking over one side, or as they're seizing, it's just one arm or one leg that's going, or if their head is, they almost look like someone with torticollis or like a stiff neck, like it's only twisted and looking up in one direction. Any of those focal features are things that I would want to know about when you bring these patients in, kids or adults. So just keeping those things in mind and then doing the stuff that you know how to do. But otherwise, I thought it was an interesting case because it was atypical from the probably sort of hordes of little kids having seizures that you see. In that one needed intervention, 2 got a pretty extensive workup and was decently sick. So that's all I got. Any other questions?
Seizures.
Yeah.
What happens if you don't see all the signs and maybe they're actively seizing? What are the worst ramifications of not treating that properly?
So At 10 or 15 minutes of a seizure, you start to see brain damage. So that's why we, at 5 minutes, we start to think about, we should probably try and get this to stop.
So I was curious,
yeah,
the timeline. you're-
Yeah, 10, 15 minutes is not great. Obviously, the longer it's going on, the worse it's gonna be. And I would, if you're unsure, if this is a seizure, obviously you have GCS, you have AVPU to try and assess like how responsive that patient is. If they're not responsive, I had a postictal patient the other day who I was leaning on his chest, trying to sternal rub him, who wasn't waking up, but he had no other signs that he was seizing. But if they're unresponsive, if they're tachycardic, that can be a sign, because you can have subclinical seizures where you don't have all of the physical manifestations.
That's why I asked, I had one of them a long time ago.
Yeah. So-
You're like, we weren't sure they were having a seizure or
Yeah.
not. Yeah.
Yeah, so if they're tachycardic, if they're hypoventilating or their end tidal is kind of creeping up, that's where like getting a cannula on early and being able to see, right? Like, oh, we started, it was 25. Now for some reason they're 40, that's strange. Yeah. I wasn't gonna comment on your age at all. And like try and assess their responsiveness. You can always call medical control, like, should I or shouldn't I give this patient Versed? It's a relatively safe medication, as long as you then pay attention to their respiratory drive after that. And I would say supporting the breathing should be the default, rather than like, I need a lot of evidence to show me that I should help this kid or should help this adult. Like, I should probably help them unless they're proving to me that they don't need my help. In terms of supporting their breathing. So I would say you can call medical control, but if you need to do Versed, that's worth trying, and sometimes it'll get you your answer. We are doing a national study looking at pediatric seizure dosing, so trying to get basically age-based norms. This kid probably could have had a little bit more. 2 doses seem to help, so they gave 3.2 milligrams. He probably could have had 5 for his age. In the end, he got 6.4. So, sort of around there anyway. But we are in the middle of a study that is a large national study, looking to see if we can get just like age range dosing for pediatric seizures. So Cincinnati Fire is participating in that, and they're like actually putting on monitors to look for seizure activity, and it kind of like dings at you if it thinks it's a seizure, basically. And so they're trying to get like actual objective data about, was this patient seizing with this kind of like small version of an EEG, so that we can know what's happening and what dose of meds is appropriate. Yeah.
So what about metabolic changes for prolonged seizure activity?
So, sometimes their sugar will go down if they've kind of like used it up. Sometimes a low sugar is the cause for the seizure. So regardless, it's a good thing to check. Otherwise, they can get basically like a lactic acidosis. So with their muscles contracting, not breathing super effectively, like all those things combined, the most common thing we see is a metabolic acidosis after seizures. And obviously that affects your body in a variety of different ways, depending on how bad it is, how acutely it came on, if there's any other complications. But I would say a lactic acidosis or metabolic acidosis is the most common thing I see, unless their acidosis is because they weren't breathing well, and then they can also have a respiratory acidosis. So one or the other. Anything else you see in adults, Dr. Richards? Other electrolyte abnormalities can contribute to seizures, but that's not something you guys are gonna be able to affect in the field. But you can stop the seizure and you can help them breathe. So.
Yeah, common things that we end up seeing on blood work that we end up usually explaining away are the lactic acid, the lactate that Dr. Cheatham mentioned. You can definitely get elevated white blood cell count, which we usually think about as infection, but they can definitely kind of demarginalize from the blood vessels and get picked up in the blood tests at higher levels. But then for all these things, you gotta think, like you said, chicken or the egg, because really bad infection like meningitis can cause you to have a seizure, right? And so Usually if you're acting promptly and you're able to get the seizure to stop, then the electrolyte abnormalities correct themselves. But that is part of like the issue, right? And so if it ends up being an undertreated and kind of subtle seizure, and they're just like not clearing, it's like, well, is it the benzo, or are they having like subclinical seizures, meaning that their brain is still having seizure activity, but they're just not having a generalized tonic-clonic seizure-like activity. What's even worse, especially if you ever do an interfacility, or if you end up using like RSI or paralytic medications, well, if you patients end up being paralyzed, they're not going to have tonic-clonic activity, even though their brain could still be seizing. And so all these situations, just high level of suspicion. I'll emphasize the point that you made, Alex, which is to say, if in doubt, just go ahead and treat with a benzodiazepine. If it's harder for them to kind of pick something up on the EEG afterward, so be it. If we're treating the seizure that much sooner, because the other part of it too is that like we, not only for this, but for most other things we do, is if we're kind of like, probably not a seizure, then recognition gets delayed on the hospital side, and then you're way down the path before potential seizure gets picked up and treated. So if you're on it and you're like, hey, we gave benzo, we think it was really good, we're on the borderline, but they were altered, they had some rhythmic motions, we went ahead and treated, more likely than not, patient's going to end up getting more treatment and more evaluation for that seizure that you're picking up. It really is, kind of setting things in motion when you're acting aggressively and appropriately so, of course. And then, kind of getting the ball rolling, and you're doing the critical care before they end up ever getting to the hospital.
And not to steal Dr. Richard's thunder, but an old person with a first-time seizure, stroke should be very high on your list. So in terms of like where you take that person and that person's disposition, new seizure in an old person is very highly concerning for stroke.
Yeah, it's not a good scene.
Cool. Well, thank you guys. Thanks for your questions. Thanks for participating. Hopefully it was a useful session. A couple of different EKGs to make you think hard about your life choices. But there were some really interesting cases this month, so I appreciate it.
Thank you.
Yeah, good month. Nice presentations. Thanks, everyone.
I had that run about 25 minutes ago.
We didn't know if the kid was seasoned the whole time or not. It was like